is Maxine Mackintosh. Yes, and so my background is that I did a kind of neuroscience and pharmacology degree, then moved into health econometrics, and then did a sort of machine learning, electronic health PhD, then a postdoc that was very disrupted by the pandemic, before somewhat leaving academia and moving to Genomics England about a year ago. Probably many of you will be familiar with Genomics England as a kind of title or an organization where you've heard the name, but many of you probably won't know exactly what it does. So I'll give a bit of an introduction in terms of the problem that the program I'm running at Genomics England is working on, give you a bit about Genomics England, and then just illustrate a couple of specific projects that myself and the team have been working on in the last year as we've kind of been setting up the Diverse Data Initiative at Genomics England. So one of the things that I just wanted to be clear on is that and I guess people will be self-selecting, and people who come to this event will probably know the intersection. But one of the things I really love about working at this intersection of sort of data bias and health inequalities is that it does bring together two very, very different churches of very deep domain expertise. But this tweet really kind of tickled me, because I think this one illustrates quite well when you kind of bring together mathematicians and people who know about health inequalities or social inequalities, that you need to be a bit clear which one you're looking at. But I do think this one for me just illustrated quite well that it is a very different and diverse skill set that comes together to work on these two issues together. So obviously I'm speaking to the converted, you've all turned up to this seminar, but data biases are definitely, feels like it's no longer a niche thing. It does hit mainstream media as well as it hits a lot of the bigger journals and major publications. And even there's, many of you will know, but there's been a kind of large review that was set up by, at the time, Secretary of State Sajid Javid into bias into medical devices, which is in kind of full swing at the moment. So it definitely feels like data biases in health are not a niche topic. And I guess importantly, it's not just a data problem. These things manifest across lots of different levels, meso, micro, macro, across lots of different points and chains in the research or clinical pipeline. And so kind of can feel a bit like a whack-a-mole of like, what is a data bias? Where is it? How does it manifest? What does it even mean? And it can quite quickly become overwhelming about where and in what way we are biasing against people. I guess one of the things to just nest all of this conversation in, and again, a lot of people in this audience will just know this, but certainly if you're speaking to particularly people who work in life sciences or people who have a genetics background, this isn't necessarily at the forefront of how people position this problem. But data are not neutral. Data represent kind of some fundamental decisions around society and how we choose to organize things and categorize things, and those get really codified in the data sets that we have. And so I really like this quote by Ruha Benjamin, and she's written a lot of amazing pieces, and she's got a really great book on particularly where race and technology intersect. But this particular quote I like. So this fails to acknowledge that data and technologies are socially constructed and embed design decisions, assumptions, values, and ideologies that can be discriminatory and generate social harm. So there is definitely a positivist approach, I feel, that in science and technology, that data does have a neutrality to it, and that is not a kind of fundamental starting point. Just to make that less abstract, I just want to give one example of how this matters particularly a lot in the world of genetics. So one of the areas which I'll talk about is the fact that we have this big bias by ancestry in genomics, and that's one of the kind of the key problems that we're trying to work on. And a lot of that is to do with kind of this fixation that humans have on categorizing other humans. We can't live in this kind of free-for-all, everyone doesn't live in a category. That's a nice utopia that we can go towards, but realistically we do have to exist in categories, and those categories are determined by and large by a small selection of the world and imposed on the rest of the world. So just to give you an example, race as a classification emerged out of the Age of Enlightenment and was really a framework that justified colonialism, and allowed people to be categorized into a smaller number of categories, and create a hierarchy against, I guess, the level of humanness and the level of sophistication between different individuals. And that came from the global north, came from a very small group of people in Northern Europe, and was imposed on the rest of the world. And so if you suddenly engage in say indigenous health frameworks, and they have a fundamentally different way of categorizing human interactions and human structures. And so it's just important to think that even the notion of race and ethnicity are socially constructed by a small group of people that has then been imposed on the world. So what's the data bias problem in genomics? So if you work in genomics, you will have seen this image 1,000 times, but for those of you who are a little bit newer to the world of genomics, the macro trend is that the number of individuals who've been contributing to GWASs over time has been increasing exponentially, which is fantastic. More people, more statistical power, more involvement, more associations, yay for more. But when you look within the numbers of individuals contributing to GWAS studies, it paints quite a different picture. So here you're looking at the redness is basically the proportions of individuals of European ancestry. And so when we say European, we are again kind of talking about sort of Northern Western European. And as you can see, it gets redder over time, very sophisticated. So there was a kind of mild improvement in the sort of 2012 to 15, where there was a rise in genomic initiatives in East Asia, but basically just more and more investment is going into genomics that is centered on individuals of European ancestry. And so whilst overall you can see an acute explosion in the field, it's becoming more imbalanced over time. And actually, depending on which way you look at it, it doesn't necessarily get any better. So this is just a slightly different way of viewing potentially the ancestral imbalance. So what this is by the number of participants in studies versus the amount of research that's published on those participants. So effectively what you're seeing here is that the East Asian initiatives punch well above their weight in terms of research output by volume, but still the proportion of individuals participating still doesn't look very rosy. And it's important to nest this in the context that obviously increasingly more and more of our healthcare, life science research is being digitized. And there has been a particularly recent background of turbulent change, particularly along the axes of ethnicity and race. Whilst obviously that's not new, it's obviously become much more limelight in the last couple of years. And when you think about diversity in genetics, it also has a bit of a kind of complex interplay of, on one hand, looking at trying to understand human migration. That's a kind of huge USP of looking at human genetic diversity. And then there's also, there's been a kind of really global explosion in national genomic initiatives. Kind of every country seems to be creating their own big biobank to represent their country. So actually, as you think of if you think of the efforts over a whole, you think actually globally we're moving in the right direction of programs happening from within continents or within countries that to date have been underrepresented. And then it's really important to know just what's happened in our kind of not so recent history. So does anyone want to boldly unmute themselves and tell me who the chap on the bottom left is?
I don't remember his name, but he's the one who invented eugenics, I'm guessing, from the picture next to it.
Yes, so that's like 50% of the answer correct. Yes, so Galton, so make sure you know your counsel, the eugenicists and geneticists, folks, because you never know where they might come up. But yeah, we have a very checkered and coloured past in recent history, particularly along, Gower Street in London, where there was a huge scientific and statistical and genetic justification for eugenics. And it's very important that that is recognized, because certainly when you are running a program like mine and you are saying to minority ethnic communities as a pseudo-government organization, hey, please give us your samples, we'll do great research that will benefit you. Understandably, a lot of those communities think, hey, we've heard that before, and that doesn't end too well for us. So it's important to kind of just nest this context in all the work that we do. So I think most of us will understand the moral imperative as to why you need data diversity. But I guess if you don't work in genetics, exactly how that scientifically manifests or the clinical implications of those that lack of data diversity might not be as clear. So there's a couple of, I guess, like quite canonical examples of how this can be illustrated in the world of genetics. So polygenic scores, a very common type of risk score that's used in genetics. This is really everyone's sort of favorite example, and it effectively is that in many traits, this doesn't apply across all traits, but in many traits, if you build a polygenic score on a population of European ancestry and you apply that score to individuals of non-European ancestry, they tend to perform well. They tend to perform less well the more genetically divergent from the Europeans you get. So individuals of African ancestry are most genetically diverse, and as you can see from this plot, on average, traits are about 4 to 5% less accurate than PRS is trained on individuals of European ancestry, so they're just not simply as transferable. Now, PRSs aren't really being used in the clinic. We're kind of really at the cusp of this potentially changing with initiatives like Our Future Health, but just from a research perspective, this is becoming increasingly more apparent. But it's not just kind of scores that that you build in a research context. There's quite a lot of words on this, but this is quite a kind of common example that we're finding. So clinically, a use case that we see quite often is variants are misclassified as pathogenic or benign based on ancestry. So in this example, looking at hypertrophic cardiomyopathy, effectively, the study looked at reanalyzing data from an existing study and brought in additional data sets and looked back at patient records and kind of reevaluated medical literature. And in this study, they found that all individuals who are of African or non-specified ancestry had received a positive report, i.e. their variant had been classified as pathogenic, when in fact the variant was benign. And that's kind of really important because as a patient, the situation is that basically your clinician might have told you that you were at high risk of developing a certain condition when in fact you weren't. And the basis for that is that variants are common in some populations and rarer in others. But if we're always comparing to a certain reference, in this case of European ancestry, you don't get to see the kind of that relative rarity or commonness reflected in the population that you're interested in. And we see this case emerge time and time again. And what that can result in is, in this case, complete unnecessary investigation and anxiety for patients in either direction. But it's not just that we kind of get the pathogenicity of a variant incorrect. Sometimes you just don't know. So there's these are things called variants of unknown significance. And so it's not that we don't know, it's not that we get them wrong, but the unknown and the error around them is greater. And so we see this time and time again that by and large, we find a high proportion of VUSs in individuals of non-European ancestry. So again, that kind of unknownness can provide a huge amount of anxiety for patients. And that is very much centered for and located much more in individuals of European ancestry, because the body of research is based on individuals of European ancestry and therefore simply doesn't translate always for other individuals. But if we do have diversity, then obviously it's not like all doom gloom. There's kind of positive angles to this as well. So a lot of the benefit, the kind of scientific and clinical benefit of genetic diversity is that you can discover new associations, and these new associations are dependent on a kind of an effect size and a frequency of a certain variant. And so there's this kind of amazing opportunity of low-hanging fruit to just discover these new associations of populations where we haven't looked at them before. So there's lots of kind of amazing use cases that have happened. So just illustrated a couple here around type 2 diabetes and around end-stage kidney disease. But it's important to recognize that also you get a much more bang for your buck if you are of non-European ancestry. So there's a kind of factoid, which is 2% of GWAS studies are of African descent, but they contribute 7% of significant associations. And that is because the African genome is, and I say African genome, recognizing that there is more genetic diversity within Africa than between Africa and any other continent. But the genetic diversity within Africa is so rich that there's a kind of huge untapped resource of looking at novel associations and novel opportunities amongst particularly individuals of African ancestry. So this is all kind of focused on the data, but in reality, there's a kind of whole pipeline from the kind of questions that we pose right at the beginning, i.e. are we only posing questions that apply to individuals of from certain countries or certain ancestries, right to how we set up study designs, obviously the data imbalances I've flagged, right to the sort of models we use, how we monitor impact in the broader context, so looking at, for example, the diversity of the workforce. All of those things in different ways feed into this system of biomedical research and data science that may or may not serve populations equally. So the Diversity Initiative at Genomics England. So this is the program I've been running for the last sort of 18 months. We're a £22 million program, and we were set up really to address this kind of huge data imbalance that we have in the UK. Technically, our data sets are broadly representative of the UK population, but in sort of absolute terms, we see pretty small numbers in lots of non-Europeans. So Genomics England was set up about 10 years ago to sequence 100,000 patients with cancer and rare diseases. Once that sequencing was done, analysis is very much ongoing. There was a sort of period of soul searching, head scratching, whereby this is all kind of learned history. I was obviously not there, whereby senior leadership felt that this great asset had been produced and there were amazing people and there was great infrastructure. And so how can Genomics England kind of transition from a thing that ran a project to maybe a platform, a more viable organization? Because we're a private company, but we're owned by the Department of Health, which I think is effectively a way to kind of be a slightly more kind of trendy, agile version of government, but it ostensibly allows us to be a bit more flexible and work, say, with the private sector and specifically pharma a bit more easily. And so now Genomics England is the platform that provides a lot of the back-end service, the genomic medicine service in the NHS. So that's our kind of live genetic testing service in the UK. We provide the back end to that. And then for patients who participate, for patients who consent to their data being used, that data then can go into our research environment and be used to do novel research. And on that kind of right-hand side, the accelerating genomic research, there's a bunch of extra initiatives that sit across Genomics England, which look to kind of supercharge that research side of things. And so Diverse Data Initiative kind of sits on that right-hand side as a way to kind of make sure that the data sets that we have coming into our research environment are as ancestrally balanced as they can be. So as a snapshot about what the program is really looking to do, we've got some kind of three main outcomes. One is around trust building for communities to date that have been excluded. We don't just mean we're looking at individuals of non-European ancestry, but these can largely be characterized broadly for people who work not in genomics as minority ethnic communities. We've got another outcome around stimulating more of the research community to look at questions of ancestry, look at questions of diversity and equity. And then thirdly, we really are here to make improvements in clinical outcomes, given the fact that we are supporting a live clinical service, and we're in a unique position to actually affect that sort of change. So we definitely, whilst we want to support research, we're less interested in questions of human migration, we're more interested in questions of kind of clinical outcomes and improvements by ancestry. So as a program, we have 4 work streams. It's kind of what it says on the tin. So these are research and discovery, community engagement, data and sequencing, and products, tools, and behaviors. So research and discovery is very much around both us conducting research into potential sources of bias and inequities within genomics, but also encouraging the research community and stimulating the research community to ask more of these sorts of questions. Around community engagement, we see this as a kind of top-down and bottom-up component. So the top-down is how do we work with either institutions like us, higher education institutions, charities, government organizations, to make sure that questions of data diversity are on their radar, that they are themselves are creating new structures, new initiatives, new projects, new programs in this space. And then the bottom up bit, which is how do we work with patient groups, how do we work with community groups to make sure that their concerns, their views, their approaches, their attitudes are captured, and then we therefore change the way that we do what we do to fit a broader church of participants. The third work stream for us is definitely the most expensive work stream. So whole genome sequencing costs, just on whole genome sequencing alone, is about 500 quid a pop. But then when you add on to that, like logistics, so, things like DHL, you add on to that phlebotomists, you'd add on to that, printing posters and doing patient engagement, it can get pretty expensive. So we're funded to sequence up to 25,000 individuals of non-European ancestry. And that will make a significant improvement and dent to our kind of our existing asset in terms of how ancestry diverse it is. And then our fourth work stream is around products, tools, and behaviors. And so this really is an attempt to be the glue between the data and the practice. So a good example is that lots of people who do genetics research will just exclude individuals of non-European ancestry. It makes results messier, makes it less clean, and often reduces your chances of getting to those higher impact journals. Now that's not obviously a data problem, that's a practice and behavior problem. And so we've just kind of realized that so much of this is around changing people's behaviors, changing people's norms, and making it really, really easy for people to work more equitably. So that whole work stream is how do we work with practitioners, be that clinicians, researchers, community activists, to make it really, really easy to do more equitable work in genomics. So our priority areas we kind of structured in this kind of tiered level, but effectively the main thing to know is our focus areas sit on sickle cell, maternal health, population genetics, that's kind of understanding human genetic variation and diversity, and then improving equity at Genomics England. So I'll just go into a little bit more detail about some of the projects and the initiatives that we've done to date, just to illustrate, you've got this huge, big issue to tackle. And so how do you actually go around, building some spawning meaningful and hopefully impactful solutions to them. So one of the things I found very challenging when I started this is that no matter what we did, someone was going to lose out. And there's this famous saying, road to hell is paved with good intention. But Adam Rutherford had a really good quote in his book called Book on Control, which is basically the book on the history of eugenics. I thoroughly recommend reading it, but maybe not reading it in public is maybe the better way to do it. But he has a really nice line that says, we must always expect science to be misrepresented, overstated, and misunderstood. It is complex because the data is unending and because people are strange. I think that's one thing that I really recognized when we started this program, is that we had an amazing resources, £22 million, and basically a blank slate. But every decision we made was going to potentially negatively impact a certain group in some way, despite our most positive and well-meaning intentions. And so how we balanced that risk and how we appropriately evaluated the decisions we made, but nevertheless progressed, was a kind of major starting problem for us. And there's no bigger problem than when you're looking on a data diversity issue, which is actually who is underrepresented. Like, how do you define who needs to be most supported in this work? Because actually, there's about 1 million different ways in which you can think about what is diversity, what is underrepresented, who is minoritized. And those things are very personal, they're very societally driven, the science on it is very messy. And so that was actually one of the most important decisions we had to even work out from the beginning, and that took us a fairly long time to do comprehensively. So one of the first things we did is we did a review of the literature to say, actually, how has the genetics community defined diversity? And it was a complete hodgepodge of definitions, probably understandably. There was inconsistent use in terms, so ancestry, race, and ethnicity were basically used interchangeably. The community was really divided as to whether this is an ancestry problem or we should be looking at things more from a societal lens. Should we be looking at things like gender? Should we be looking at things like socioeconomic status? And it was just very clear from the literature that very few studies looked at our outcome of interest and said, okay, based on our outcome, what are the axes we need to diversify by? Because simply just having diversity that's not tied to an outcome doesn't actually necessarily further your scientific aims. And that just became very, very clear that there was almost a push of diversity for diversity's sake without really fully explaining why. So we also had a review of our own data to say, okay, what's our starting point within Genomics England? What does that really look like? As you can see, we are obviously dominated by individuals of European ancestry. That's the big green blob. But actually, when you look across other ancestral groups, we are technically fairly representative of the UK population. And so that was an interesting starting point for us, because he said, well, actually, if representativeness is something that we want to gun for, we've kind of got there already. And very quickly we realized that simply representativeness was not good enough, because representativeness in the UK still means the dominance of individuals of European ancestry. So this was the case as well with cancer. We found that actually when we looked at how our kind of rates of cancer by, our prevalence of cancer by ethnicity, in this case it was the category that was used, reflected what we'd expected to be based on the national population. Again, we performed fairly well. We were pretty representative. We didn't see any kind of major discrepancies. But then after kind of doing a fair amount of digging, we started to realize the subtle ways in which some very specific outcomes of interest may have some ancestral bias for us. And I won't go to this in too much detail, but I guess the point was that it took us quite a long time to work out subtle ancestry signals and ancestry bias signals in our data. And despite the huge data imbalance, we actually anticipated us to kind of be, have huge diagnostic yield differences by ancestry, or for us to see major differences in accuracy and performance, or time to diagnosis to be much larger for individuals of non-European ancestry. And we simply didn't see those signals, which kind of made us realize that actually surfacing sources of bias inequity is in of itself a very challenging, complex thing to work on. So one of the things we did is we went around the organization, we said to people, okay, so you've got £22 million, where would you prioritize your efforts? Which groups would you go to? And what's your kind of frame of reference for how you think about who is underrepresented? And literally everyone had a different answer. So some people saying, well, actually, if I were you, I would just try to create a data set that was representative of the UK ethnic population. Some people saying, well, actually, we want to future-proof it to make it representative of the UK population in like 15 years. Other people saying, well, we really should recognize the global context here. So we should be looking to be globally ancestrally representative. And actually, the UK is a really good place to do that. Other people said, okay, actually, I'm going to take a bit more of an economic approach. I'm going to say, actually, we should focus on cohorts that have the biggest cost savings to the NHS if we're able to do amazing research on it. And some people said, well, really, we should focus on groups where there's the biggest potential for discovery. So, for example, individuals of African ancestry. Other people said, well, really, you should just make this a really consultative process, do some big consultations, say, the UK, tell us what you think we should work on. And other people said, well, really, you should focus on areas that to date have been completely neglected. And so really importantly, that gives you fundamental different strategic outcomes depending on which one of these you select. And I appreciate this is like a slightly crappy clustering of the different views, but it did make it quite challenging for us to hone down, I guess, the conceptual positioning that we wanted to do for the program. So we then took these different buckets of framing the problem and we compare these against an agglomeration of bioethical principles and just did a bit of an evaluation. And so this is a kind of it's a midpoint screenshot of what we did here. And I guess this was an important exercise because there's not a wrong or right answer here, but it's important to acknowledge that in choosing one of these approaches and choosing one of these frames of reference, you're making a very values-based judgment on how you think about and are conceptualizing diversity or underrepresentation or minoritization. And so this was we've kind of made this into a toolkit because lots of individuals that are looking to improve equity need to go through this process. And I guess maybe one thing that we've realized is that the maybe organizations or projects or programs aren't necessarily very good at explicitly recognizing that there are values that underpin this first and foremost, this decision. In parallel, we started to kind of excavate Genomics England for what and where there could be a source of bias in our pipeline. So I don't know if you remember that slide I showed that kind of showed that the bias from the questions we pose to the data we have to the models we select to the study design, etc. We then took that framework and applied it internally. And so what you're kind of looking at is a very chaotic mirror board of identifying every single step in our diagnostic pipelines and articulating exactly a potential source of bias in that very step. And that could be a source of bias because of a process thing, it could be a behavior thing, it could be a threshold thing, it doesn't really matter. And we just tried to kind of go through as much of the organizations we could and represent that as a kind of schematic of bias. And this is a kind of really interesting activity because, effectively what you're looking at is a map of how Genomics England is killing some people and not others, effectively. It's a pretty scathing diagram and activity to put together. But the important thing that we wanted to recognize is that there is no organization that's processing data that is bias-free. And so just being very explicit about where there could be discrepancies or variation is really, really important. And this process was quite challenging for us to really get into full swing, because obviously the moment you talk to people to say, how do you think your work is biased? Most people are like, well, I'm not biased, I'm a scientist, and actually, this is the work that I do, or I just do this process, or like I just take this step. And people are both defensive or unaware. And actually it took quite a long time to really coax out of people that at every point in the day we're making decisions, and those decisions may or may not bias certain groups. So just to give you kind of one really like small, somewhat silly example, is that when you sign up to our research environment, if you have a special character in your name, on average, it takes you 2.5 weeks longer to register for our research environment. But kind of because of a computer says no problem. And obviously you're much less likely to be of kind of English heritage if you have a special character in your name. And so even that like tiny little thing is a good example of how we are creating a system whereby individuals who are maybe not of European or English heritage may not be served as well. So one of the things we did is, because this process obviously exposed and surfaced a huge amount of different small ways in which we are biased as an organization. Our design researcher, Sophia Liu, who is absolutely fantastic, created this kind of visual representation of how you, I guess, can bucket levels of bias so that it's a bit more manageable. Because otherwise you end up being like, whoa, I have to deal with institutional racism by lunch, and it gets quite overwhelming. So on the left-hand side, you're seeing a building. So everything that's the grey bit is everything that's below ground, is everything that happens to data before it hits Genomics England. And then what you're seeing is that as you go up the tower and then you end up hitting those helicopters, you go up those pink steps. And each one of those pink steps is a kind of macro decision that happens in Genomics England. Then if you go look at the middle framing, you're basically looking at a blueprint of a floor plan there. And each one of those boxes is a room. And in order to go from one end of the floor to the other end of the floor, you have to go through all these different rooms and these different doors. And again, each one of these doors and rooms represents a decision boundary and a decision point. And again, the point is that we have to be making these decisions, but these decisions will be introducing a source of bias. And then the third bit, the room, is that we've got like tapestries and cacti and sofas and who knows what. And these are very, very specific point problems that we've identified, that all of a sudden becomes a lot more manageable to build a solution towards. So, the special character name is a really good example of one of those tiny kind of small point solutions. So this was quite a useful kind of communication tool for us to say, yes, there's the big stuff, but actually this is how we can salami slice it into things that become a little bit more manageable for us. So once we had kind of gone through that exercise of understanding like who's underrepresented and what is a bias, and that gave us a little bit more of a scaffolding to operate within. We also recognized that whilst a lot of the narrative has been focused on the data being imbalanced, and I guess a bit more of the strategic, as a bit more of the systemic and social factors surrounding it have, I guess, been brought to light. So thinking about, say, global imbalances in funding by institution. We did find that not as much attention had been given to that kind of products, tools, behavior side of things, i.e., how do you make it really easy for an individual who's just trying to make their work a little bit more equitable? Like, how do you make it really easy for them to practically implement change? And so we started building a bunch of different tools. And so I just wanted to illustrate this with a couple of tools and a bit of an environment by which we're making tools. So we created this toolkit called Lost in Translation. And this is an interactive tool which effectively gives you guidance on which terms to use in genomics, in what way and with what context. This has been kind of co-created and co-designed to high heaven, and it is very interesting because it's partly very controversial. Language changes all the time. Language is incredibly context-specific. Language is incredibly personal for different people. And we are also an institution that is now arguably defining what words people should and shouldn't be using. But one of the things we found was that many people wanted to be better at working in diversity in genomics, but they were terrified of being sort of accidentally really discriminatory or racist in the words that they were using. So fear of offending was stopping a lot of people just making that first step of engaging in the topic full stop. And after kind of a lot of interviews and engaging with people, both at Genomics England and also people in the research community, some people said, I actually couldn't care less what the debate is. I just want you to tell me what words I can use when, like, is BAME in, is BAME out? Are people talking about ethnicity? You know, are we allowed to say global north, global south? What's the crack? Basically, most people said, I don't want this to be a big part of my life. I just need you to tell me what is or isn't appropriate at the moment. And then other people said, I really want to understand the full debate. Why is there sensitivity? Why is there nuance? And how do I use it in different settings? So for example, if you are in our case, if you are engaging with a bunch of different communities in South London and you start talking about individuals of African ancestry, unsurprisingly, many of them turn around to say, can you just talk about Black? Like, it's really annoying. You keep saying African ancestry. I'm Black. Just call me Black. And so that it's really important to understand that these things have different contexts. So this is a really interactive tool, and we'll be publishing it kind of openly in next month. And the idea is that based on your project or program, you can move terms in different ways. You can adapt it, you can use it as a template, or you can just use it as is, but it's hopefully providing you a little bit more guidance about how to use the right language in the right way. The next thing I just wanted to flag up is a project called Link 23. So you can view it at link23.world. So this has just been launched. And this for us is a project that we've collaborated on with a whole bunch of other institutions and organizations across the world, which is how do we create a global community and environment to make open source tools to improve equity in genomics. So for us here, a tool is everything from a model that deals with sample imbalance and allows you to do some reweighting, right, to a handbook with how do you speak to Papua New Guineans about genomics. Like for us, a tool constitutes at that range. But we wanted to make it a little bit easier for people to find those tools, build on existing tools, not reinvent the wheel, adapt tools and implement those tools. So what we've currently been doing is basically collecting any tool that we think is somewhat related to genomics and equity, creating a kind of master list of that. We're starting to put some additional metadata around it, tagging it with kind of useful tags that means that it's more searchable and more usable. And then we're going to start to run some challenges through Link 23 that address specific technical or practical based problems. So one of the first ones we're going to do is we're going to run a project called Transferability Challenge. So the idea is that we harness a global community of people working in genomics and equity to work on these problems together, build solutions and make those solutions publicly and openly available for everyone to use. So it's still early days, but it's been kind of wonderful to see this get off the ground, and it's certainly clearly addressed a need because I don't think that to date this area of the genomic equity space has been given as much attention. And I guess kind of last but not least, and everyone here probably things like inequalities and digital health is quite a big part of their life because you turn up to this seminar. Funnily enough, like most people don't really care about it and think it's pretty niche. And so just recognizing that this is quite niche, but also very, very important. And, you know, it does have quite a lot of technical stuff around it and can be a bit dry. We created a crowdsourced storyboard called, you can find at mindthegap.health. And it was put together by this amazing artist in London who is just a delight to work with, called Lily Gong. And this basically just gives a series of stories, and that's stories in terms of summaries of research, personal patient accounts, videos, poems, data visualizations of where data science and health equity and data bias all intersect. And it's just meant to be a resource for people who, you know, want to learn more but don't want to necessarily have to read papers about it. So by all means, visit it. We are always looking for people to submit a story, and it can be as sciencey or not as you want. As I said, someone's created a whole collection of data visualizations, and that was their submission. So kind of anything goes. We're up for it all, but by all means, check that out as well. So the team at Genomics England is completely awesome. I've never had the privilege of working with like designers and ethicists and bioinformaticians, and it's just been a completely wild ride. But obviously most of what I presented is not me. My job is basically building Gantt charts and writing emails, but it's been very fun to work with such an amazing group. So I will pause there. And I appreciate I spoke very quickly, but any questions or to dig down into specific projects, then happy to use the time now to go through that. Thank you very much for listening.